since the Professor Lee and Professor Mitsudomi bring out the JCOG 0802 trial. So I have question for the Professor Mitsudomi, because we know that after 5 years follow-up, it shows that sigmoidectomy is not inferior to the lobectomy. But after 10 years follow-up, it seems that still the lobectomy is better, brought the patients a better overall survival after the long follow-up time. So how do you think this result? And the question is, how do we set the endpoints for the perioperative treatment studies for this early stage lung cancer?
Yes. Actually, the trial was initially planned for the non-inferiority trial, but actually not just the non-inferiority, there is a superiority of the segmentectomy and at the initial analysis. So the segment, in terms of the overall survival, segmentectomy was significantly better than the lobectomy, but there's no difference in the recurrence-free survival. And in the 10-year follow-up, the data will be presented in the AATS meeting, which is in May, early May. So I cannot say much about the 10-year follow-up data, but the curves are a bit approaching compared to the 5-year analysis. And local recurrence is more frequent in the segmentectomy, but the overall recurrence is similar. And lung cancer death is similar. What is different is non-lung cancer death is more frequent in the lobectomy arm. And what is non-lung cancer death? It's mostly non-lung cancer death, like gastric cancer, breast cancer, things like that. So, but we can explain why non-lung cancer death is more frequent in the lobectomy arm. Also, there's a very small difference in terms of the first exploratory volume 1. So the lung function was not so good, or about 3% better. I mean, the reduction of the pulmonary function difference is only 3%. So that is, initially we expected there may be at least 10% difference between the segmentectomy and the lobectomy, but there was only 3%. So in terms of the lung function preservation, there's no big effect, but the overall survival is better than the segmentectomy. And what makes the difference is the frequency of the non-lung cancer death. So this is very puzzling results. But at least there's no big difference. Considering with the CLGB trial, at least if you select the patients like small lung cancer, there's no big difference between the segments. That's the common findings. But in the case of the CLGB trial, there's no difference in the non-lung cancer death. So it's a bit confusing, but I think depending on as I told you earlier, that depending on the patient condition, tumor location, some other factors, you can discuss with the patients which is the most appropriate treatment for particular patients. That's my thoughts.
Okay, and my question is that if you design adjuvant therapy clinical trial, which endpoints would you like to select? Still overall survival for this adjuvant therapy, or the EFS or DFS for this trial? The primary.
So your question is not about this early, I mean, small tumor, right? That's adjuvant therapy in general. Right?
For the adjuvant therapy.
In general, right?
Yeah, in general.
Yes, I think that the overall survival is most important point, but it may take long time, right? It will cost a lot, so sometimes it may be difficult, but I think that the overall survival is most important endpoint. EFS is still surrogate, I think.
Okay, and the last question is about the staging. we know that the ninth version of TNM staging, we didn't include any pathological high risk factor inside. So do you think that when we stage a lung cancer, especially for the very early stage, like stage 1A, I know that some surgeons, they might give the adjuvant therapy for the stage 1A if the patient has some high risk factors.
Yeah, so that strategy, yes, I completely agree with you. I mean, that histologic types like Surrey type or Asina type, or those known to be micropapillary, those are known to be very worse prognosis. So ideally, those factors should be incorporated into the staging system. So that maybe the next version will incorporate those histologic types as well as they say that the molecular features will be also included. But for now, I mean, the ADORA 2 is now exploring the benefit of the osimertinib for the 1A, 1 or 2 or 3 patients with aggressive features like histologic types or those kind of things. So, yes, you are right. I think that in the future we may have to give some adjuvant therapy even for the stage 1A patients with some bad features, right?
Okay, thank you.
Thank you.